12 o'clock complex skills class, and I'm doing my project on CHF. CHF is a chronic progressive condition that affects the way your muscles pump blood to the heart. It's often referred to as just heart failure. There are many subjective questions that may elicit signs and symptoms of this condition. For example, chest pain. Do you have any chest pain or discomfort, like a burning, stabbing, aching, or heaviness feeling? Is the pain in one spot or does it radiate? How long have you had this pain? Does it come and go or is it constant? Can you describe how it feels? What brings it on? Is there any activity or stress-like feelings that make this pain any worse? Do any other symptoms occur when you have pain? And what works to relieve the pain, whether that's medication or sitting upright? Have you experienced any shortness of breath? Is your shortness of breath depending on your position? How does the shortness of breath affect your daily activities? And how many pillows do you sleep on at night? Do you have a cough? Do you cough up mucus? Is coughing associated with any activity? Is the coughing relieved by anything? Are you tired easily? Is your energy level related to a time of day? Have you ever noticed a bluish or ashy color to your face? Have you noticed any swelling in your feet and legs? When did you first experience swelling? Are both feet swollen to the same degree? Have you had any history of heart disease before? When was your last ECG? Do you have any family history of heart disease? What is your daily diet like? Have you noticed a weight increase? Have you ever used tobacco? How often do you drink alcohol? How often do you exercise? And do you take any cardiac medications? Some common symptoms you may notice during inspection are dilated pupils, as that's a sympathetic nervous system response. The skin may be pale gray or cyanotic. You may notice shortness of breath, as that's an early symptom from pulmonary congestion. Orthopnea, which means the patient has trouble breathing unless they are sitting up. They may have a cough, which produces frothy pink or white sputum. They may have nausea or vomiting as peristalsis slows and bile fluids back up into the stomach. The patient may be experiencing anxiety, gasping from pulmonary congestion. The patient may seem confused from decreased O2 to the brain. Their jugular vein may be distended from venous congestion. They may be tired or weak from decreased cardiac output. And you may notice a decrease in their urine output as kidneys compensate for decreased cardiac output by retaining sodium and H2O. During palpation, you may notice that the patient has a weak pulse. Their skin is moist and cool to touch as peripheral vasoconstriction shunts blood to vital organs. You may notice some dependent pitting edema in the sacrum or the legs. You may notice an enlarged spleen and liver from venous congestion, which causes pressure on breathing. Their tactile phremitis would normally be normal. And during percussion, you will notice a resonant sound. That's a low-pitched or hollow sound, and abnormal cardiac borders. During auscultation, you may hear normal vesicular breath sounds. You may hear crackles at the bases of the lungs or wheezes. You may hear an S3 gallop, which is just after the S2 heart sound when the mitral valve opens, allowing passive filling onto the left ventricle. The heartbeat is usually beating faster than normal, tachycardia, and you may hear ascites, which is the abnormal buildup of fluid in the abdomen. Blood type matching is based on the presence or absence of A and B red blood cell antibodies in the blood. O blood has neither A or B antigens in their blood and is considered a universal donor. People with type AB blood produce neither antibody, which is why they can be universal recipients. Rh factor is an antigenic substance of erythrocytes. A patient is either Rh positive or Rh negative. Blood must be matched not only for the ABO group, but also for the Rh factor. Rh negative patients must receive only Rh negative blood, whereas Rh positive patients can receive either Rh negative or Rh positive blood. If incompatible or mismatched during a transfusion, a reaction may occur. The patient's antibodies trigger red blood cell destruction, and the response ranges from mild to severe anaphylactic shock or acute intravascular hemolysis, both of which can be very life-threatening. Blood transfusions are directed towards patients who are increasing circulating blood volume after surgery or a trauma, or the number of red blood cells to maintain hemoglobin levels in patients with severe anemia, or to provide cellular components as replacement therapy like clotting factors. Equipment and solutions for blood transfusions involve a vitals machine, the blood being used, saline, a catheter, IV needle or cannula, and Y-type tubing with a filter. Blood is administered with an 18 to 22 gauge catheter, IV needle, or cannula. Larger needles may be used during rapid transfusions or if the infusion is sluggish. It's important to assess the patency before obtaining the blood from the blood bank. Blood is administered through a Y-type tubing with a filter. The one branch is used for the blood product and the other is used for saline. The vitals machine is of most important because you need a baseline set of vitals before you go ahead with procedures so you can see if there's any adverse reactions happening. Rate and monitoring. During the first 15 minutes or 50 milliliters of blood infusion, the nurse should remain with the patient to observe any reactions. The rate of infusion during this period should be no more than 2 milliliters a minute. If infused too quickly, the patient can become chilled. If a rapid infusion is needed, a blood warming device will be used. After the first 15 minutes, vital signs are taken again, and the rate of infusion is increased to the original order by the doctor. The nurse should check in on the patient every 30 minutes and up to an hour after the transfusion is over. Most patients will receive 1 unit of red blood cells over 2 hours. The entire process should not exceed 4 hours due to bacterial growth from the blood not being refrigerated properly. A transfusion reaction is a systemic response by the body to a foreign protein. We have acute reactions and delayed reactions. If an acute reaction occurs, stop the transfusion, maintain a patent IV line with saline solution, notify the blood bank and the healthcare provider immediately, recheck identifying tags and numbers, monitor vital signs and urine output, treat symptoms as per physician order, save and return the blood bag and tubing to the blood bank for examination, collect blood and urine samples, document the incident on a transfusion reaction form and the patient's chart. So I'll talk about an acute hemolytic reaction. This is an infusion of ABO incompatible whole blood red blood cells or components containing 10 mils or more of red blood cells. These are when the antibodies in the patient's plasma attach to antigens on transfused red blood cells, causing a destruction. This usually occurs within the first 15 minutes. This comes with a fever, with or without chills, low back, abdominal, chest, or flank pain, tachycardia, shortness of breath, acute jaundice, dark urine, bleeding, acute kidney injury. This can lead to shock, cardiac arrest, and even death. So a febrile reaction is a sensitization to donor white blood cells, platelets, or plasma proteins. A circulatory overload reaction is fluid administered faster than the circulation can accommodate. Sepsis reaction is transfusion of bacterially infected blood components. Massive blood transfusion reaction can occur with replacement of 10 or more red blood cell units within 24 hours. Red blood cell transfusions do not contain clotting factors, albumin, and platelets. As for delayed reactions, there's a delayed hemolytic reaction, which is similar to the acute. You'll see a fever, mild jaundice, decreased hemoglobin, but this can occur as early as 3 days or as late as several months after your transfusion. This is the result of destruction of transfused red blood cells by alloantibodies not detected during cross-match. As for infections, there's hepatitis B, which causes an elevation in the liver enzymes, which can cause anorexia, malaise, nausea, and vomiting, fever, dark urine, and jaundice. This usually resolves within 4 to 6 weeks, but can result in permanent damage to the liver. Then for hepatitis C, the symptoms are usually less severe than hepatitis B, but chronic liver disease and cirrhosis may develop because of it. As for an iron overload, this means there's excess iron deposited in the heart, liver, pancreas, and joints, causing a dysfunction. This can lead to heart failure, dysrhythmias, impaired thyroid function, diabetes, arthritis, and cirrhosis. This usually occurs in patients receiving over 100 units for chronic anemia or patients who have sickle cell anemia.